study number 1. 12-year-old boy comes into the ER, severe complaints of nosebleeds and a rash on his arms and legs. His medical history was flu-like symptoms. On physical exam, he presented without hepatomegaly, splenomegaly. His only abnormal lab values included platelets of 2,000. The rest of his CBC was within normal limits. Red cell fragmentation, schistocytes was normal. Anticoagulation studies, including PT, PTT, INR, fibrinogen, D-dimer, all within normal limits, and his ANA was negative as well. So ITP is normally a diagnosis of exclusion, so they were able to rule out anemia, systemic lupus erythematosus as well. The leukemias and lymphomas were ruled out because of his normal CBC, his DIC as well because of the schistocytes or red cell fragmentation. There was no presentation of antiphospholipid antibodies. He was not being treated with any heparin, so HIT was also ruled out. Normally, when there's an admission of a possible ITP, a bone marrow is conducted, but in this case it wasn't. And he was supposed to have a virus on admission. So the suspected pathology of ITP includes IgG or IgA antibodies in the patient's blood to bind to the antigens on the membranes of the circulating platelets, therefore destroying them. Originally, ITP was thought to occur by viral stimulation, and it resulted in a cross-reaction with the existing platelet epitopes. But more recently, studies have shown that these antibodies are directed against the glycoproteins in the integralin family, presenting the formation of new platelets via the inhibited megakaryopoiesis or the destruction of the megakaryocytes within the bone marrow. As far as genetic factors that affect ITP, single nucleotide polymorphisms are the most common DNA sequence variations. Usually, cytokine responses and dysregulation of the network are what's responsible for the immune-mediated inflammatory response. Cytokine polymorphisms are allowing distinct alleles to be associated with the immunoinflammatory disease process of ITP. The immune-regulating cytokines include IL-4 and IL-10. IL-4, which is inducing the activation of the differentiation of the B cells. IL-10, the most important anti-inflammatory cytokine, which potently inhibits the T helper 1 cells. This study was specific to ITP in Egyptian children from acute and chronic, as well as including that specific control group. Basically, their role in modulating the susceptibility of ITP within the correlation and the clinical expression amongst the lab data and the gene expression on the length of the PCR. The specific associations were the T helper 1 cells did induce the autoimmunity, and the T helper 2 inhibited the immune responses. Even though ITP is associated with the dysregulation of the cytokine responses, the biggest correlation was that chronic ITP proposed the characterized T helper 1 counts in the high Th1 and Th2 ratio, which was the only real true correlation amongst the cytokines and the disease process of the ITP. Basically, the results showed that patients with mutations of IL-4 and IL-10 were not at a greater risk for ITP, but were most likely to have chronic ITP. Nonetheless, further discovery in polymorphisms amongst those cytokines may exude further association between the mutations and the pathogenesis of ITP amongst the chronic disease altogether. The American Society of Hematology conducted a study on how microRNA regulate the immunological pathways in T cells in ITP. The study focused on how microRNA in plasma levels of the target gene CXCL13 differ between ITP and controls, indicating that microRNA may be important in ITP. To better understand the genes and mechanisms involved in the organ-specific ITP, they studied the gene and microRNA expression in the T cells, differentiating between chronic ITP patients and healthy controls. Initially, they identified 1,915 regulated genes in the peripheral blood T cells between the ITP patients and the controls. They used a specific project called the GO project, which was a collaborative effort to address the need for consistent descriptions of gene products within this specific disease. Next, they compared the differences in expressions of microRNA in peripheral blood T cells and found that 22 microRNA expressions were significantly different with ITP patients, as well as 16 small nuclear RNA and small cagal body specific RNA were also different in regards to the ITP patients. To better understand the role of the regulated microRNA in ITP patients, they identified the predicted target genes of the significantly regulated microRNA using advanced, highly scientific tests like the target scan and the Miranda algorithms. It resulted in 7 different immunological results that were the T cell activation involved in immune response, the natural killer cell differentiation, regulation of immunoglobulin production, positive regulation of leukocyte activation, lymphocyte activation involved in immune response, lymphocyte differentiation, and co-stimulation. Not all of the results were new. Some of the results were already known mechanisms behind ATP For instance, the production of platelet autoantibodies that is seen in approximately 50 to 60% of all chronic ITP patients. Already known findings included the response to stimulation of whole platelets or fragments of GP2B3A and GP3A in ITP. Also, that cytotoxic cells can lyse the platelets in patients with ITP. B cells and T cells are vital to the pathophysiology of the mechanisms in ITP, and it led to the conclusion that the regulation of the microRNA in ITP can significantly affect both the gene and protein expression in T cells, indicating an importance, making them regulatory molecules involved in the loss of the immune tolerance in ITP altogether. ITP can be either primary without a known cause or secondary to diseases like HIV, Hep C, infections, sepsis, liver disease, any type of chemo or cancer. It occurs most likely in patients older than 60. However, I've personally seen ITP across a lifespan and even in pregnant mothers. It is usually diagnosed with a routine CBC. It is a diagnosis of exclusion, and patients will be presenting with bruising throughout and even sometimes epistaxis. Women usually get it more common than men, especially during pregnancy, like I mentioned before. Upon diagnosis, it is important to go through past medical history and medications, because certain medications may be interacting and causing the low platelets or bleeding. Some examples are Tylenol, cimetidine, Bactrim, tamoxifen, haloperidol, diazepam, with a slew of others. A full medical history includes: does the patient bleed frequently during surgeries? If the patient's a female, does she have heavy menstrual cycles? Physical examination is very important. Evaluating the bruising, the petechiae, feeling the abdomen for the splenomegaly, and examining the mouth for any sores or bleeding as well. Always including the labs and a blood count is vital, including the manual differential. Identifying the shapes and sizes of the cell is also pertinent to the diagnosis of ITP, yet it can't be diagnosed with just one thing. It's a slew of assessments together. Treatment for this disease can be tricky because it depends how low the platelet count is altogether. Usually children will receive 2 IVIG infusions and the disease will be self-limiting after that. Otherwise, patients are put on steroids and receive the Phlebogamma, but most often that is because they are symptomatic. Otherwise, treatment can negatively affect the quality of life, and patients can become severely depressed and concerned. Nursing care, when referring to ITP, is usually supportive care, usually a lot of teaching and learning of the verbiage, learning of the platelet count numbers, knowing what to look for, preventing any type of bleeding, using electric razors, soft toothbrushes, any type of ice for comfort care, and of course monitoring the petechiae. It's important for parents to protect children from hitting their heads because there's a huge risk for intracranial hemorrhaging. So there's a lot of treatment with that. Also, how to treat nosebleeds, and through the process, allowing the patient and their family to choose the best treatment from there once you've presented them with all of the information, and reminding them that this is a very much a livable disease, that the risk of death is quite minimal, but there's a lot of maintenance therapy that does go along with it.